Thank you, Dr. Ellis. Welcome everybody this morning. We're going to try to fly through kind of a whole lot of topics related to ACL tears. So if anybody picked up the paper this morning, they would clearly see that ACL tears in pediatric patients are definitely on the rise, and this is definitely something that's a very important topic to cover. We know that specifically here and in the patients that we treat that this is our highest risk population. That those kind of between the ages of 11 and 18 are really high risk, not only to develop the injury, but also have recurrences. So there's a lot of incentive to develop strategies to help prevent the injury before it occurs. We know that there's many consequences to this injury other than the ligament tear. The lost time in sport, potential scholarship earnings in those that are developing skills to potentially take those to the next level. Both the short-term disability that's associated with the surgery, the pain, and the recovery, but also the long-term sequelae of the injury that may be developing arthritis in the 10 to 30-year timeline. And not to consider the financial impact of the injury, that an ACL reconstruction costing anywhere between $15,000 and $17,000 per incident, that this is a billion-dollar industry across the United States. So there's a lot of financial incentives to try and not only limit the occurrence, but to help decrease the reoccurrence of it. A lot of speculation we'll hear this morning about a lot of different factors that are associated with this. Some of these are modifiable, some not, but there's a lot of speculation that we can all agree that most of these injuries occur during activities that involve decelerating, pivoting, or changing directions. And we know that the majority of these are non-contact injuries. Globally, I'm going to talk about specifically risk factors, and I'd like to kind of divide those into 4 different categories. So we'll kind of go through each one of them and hit the highlights of those specific things. We'll start with kind of environmental. Environmental, it's easy to see that there's definitely an influence of the shoe surface interaction, okay? So that we know that actually this was a study that was done actually out in West Texas by Bill Barnhill. They looked at 2 different high schools. They had one in Amarillo and one in Lubbock, and they compared both of those, and they looked at the incidence of injuries over a 5-year period on field turf and on natural grass and kind of compared those. It's pretty interesting. There is some definite flaws in the study. That wasn't really the purpose of seeing this, but the point being that we know that there's a direct correlation. And any athletic trainer or PT or anybody that's covered a game, I always enjoyed covering rainy or sleety, yucky games because nobody gets hurt. But there's a definite influence, and as the coefficient of friction goes up with the shoe and the surface, we know that performance goes up. Okay, but that may be associated with increased forces through the joints that may be a risk for injury. Bracing is a really hot topic. Bracing's been around for a long time. We see this brace on Dan Marino's knee that in the 80s, and there was kind of this development. There was a study out of Iowa State that looked at theirs, and they actually reported an improvement in knee-related injuries with the use of bracing. But over the late 80s and into the early 90s, there was actually a few studies that actually reported an increased risk of injury associated with this. This was a pretty good review by Jorge Chala in 2021, demonstrating actually, I was pretty blown away by this. They kind of surveyed a bunch of academic institutions and orthopedic surgeons, and only about 25% of them actually made a formal recommendation for functional bracing. There's a lot of considerations for this as far as individual sport, personal biases. There are certainly benefits from a proprioceptive standpoint, and decrease stress and strain on the actual graft, but we really don't know what the value is of bracing on risk of injury. So there's certainly anatomic factors. We talk about the concept of static versus dynamic valgus. We know that females have certainly more hip varus and knee valgus associated with foot pronation, that this can be a risk for injury. We know that notch width, the intercondylar notch width, and associated size of the ACL may be a risk factor. That those with bilateral injuries, we know that their notches are likely much more narrow than those without ACL tears. We know that tibial torsion, Keith Meister has some unpublished data that he did a matched cohort of injured knees and uninjured knees and showed kind of an increase in thigh-foot angle of those particular patients. This is a continually developing topic that du jour described posterior tibial slope and its linear correlation between slope and anterior tibial translation. We know that there's a direct correlation between that is a poor prognostic indicator both for development of injury but also recurrent tears of the ACL. Hormonal influences have been studied for many, many years. Dr. Liu was able to demonstrate in about 17 or 18 cadavers the presence of estrogen progesterone receptors in the human ACL, and Dr. Slaughterbeck out in Lubbock at Texas Tech Health Science Center also demonstrated that the presence of estrogen in ovaryectomies in rabbits demonstrated increased failure load of the rabbit ACL when it was exposed to estrogen. So we know that it no doubt has an effect of it. In fact, there was an attempt at modifying this and placing athletes on oral contraceptives to modify this risk factor, but that's actually not been shown to really decrease those rates of injury in those athletes. So we know that that's affected, and it's probably a variable that's associated with female injuries, but still much to be determined. And from a biomechanical standpoint, I'll fly through this because I know Sophia and Jessica are going to continue to follow this, but we know that this concept of functional joint stability is a very complex one. Of all of those risk factors that we previously discussed, this is likely one of the only ones that's really modifiable. So this is where a lot of our research is really focused. That we know this complex interplay between proprioception, or ability to kind of know where the limb is in space, and the neuromuscular control is certainly a very strong factor. That this is more than just about the knee. This is about the kind of the position of the hip or the foot and the influence that those particular joints have on the knee. And then other influences that are associated with it that we can be pretty good at teaching the athlete how to function without a basketball or without other players on the field, but when we associate unplanned alterations in their movement patterns, that this may be associated with injury, and that's where a lot of our therapy is really designed to try and influence.
Okay, I'll just get started. So I'm Sophia Ulman. I am the director of the Movement Science Lab here, and I'll be speaking on injury prevention. A lot of what I'll say, a little bit of it will echo what Ben said, but to start, we're probably pretty familiar with these stats. About a fifth of our knee injuries are due to an ACL, and the majority of them are non-contact injuries. And because of that, a lot of research has focused on how to prevent them. This is a 2022 umbrella review that does a very nice job of going into different injury prevention programs and their effectiveness, and so I'll kind of stick with this article throughout. So this article, as we all know, shares that females are at 2 to 8 times higher risk of ACL injury, and because of that, a lot of the studies have focused on female athletes. Like Ben mentioned, contributing risk factors include sex-specific anatomical factors and hormonal factors, as well as neuromuscular and biomechanical factors. While the first two are not modifiable, the second two are, and have been shown to be injury prevention programs and neuromuscular training has been shown to modify these successfully, and they can be done and be successful in both female and male athlete populations. So what do these include? Your medial knee collapse, reduced hip and knee flexion, poor core strength, poor hamstring strength. All of these risk factors are really getting at poor muscle weakness, stiff landing patterns, poor stabilization, and poor spatial awareness. So in an injury prevention program or a neuromuscular training program, you're going to want to target these areas. And this umbrella review went over 10 of their most popular programs and how they do this. So while they differ in the components they have, some of them have, all of them have plyometrics, but some of them have strength, agility, balance. They're all trying to prepare and improve the athlete's ability to avoid these high-risk movement patterns. They differ in components, but they also differ in implementation. So you have to consider duration, frequency, length of program, and the training season as well. I'm not going to get into the details of which program is the best. The review does a good job of sharing that in the literature, it's hard to know which program performs best because they're going to be, some of them are going to be sport specific, You're going to have different participants, different sample sizes in these different articles. But the main takeaway from the 2022 review was that out of the top 10 programs, they found that just implementing an injury prevention program is going to reduce the rates of ACL injury, specifically here, by 64%. So just implementing some kind of program is going to be impactful, and making sure you do that to the best of your ability. So the recommendations to implement that program. Evidence does not say which component is going to be the most impactful or the best, but a multifaceted training program is going to be beneficial. Not only one, you can't just use one exercise or one component. You can't just do plyometrics or just do agility or just do strength training. It's important to have a multifaceted program. And the review recommends at least 3 to 5 different exercise type combinations. And I'm going to use the FIFA 11 as an example, not because it is the best, even though it has been shown in the literature to perform pretty well and be effective, but because it's free, it's online, and it is the most widely adopted, according to the literature. So while the review says they're not going to tell you which component is the best, they do rank them and recommend them in a certain order. The first being plyometrics. All 10 of the programs they reviewed include some kind of plyometrics and some kind of plyometric exercises. And it's important to realize if you implement these in a training program, you have to give feedback on the technique. If you're doing a high impact game-like task in your training program, you need to make sure they're doing it correctly and with the correct mechanics. Otherwise, it's not going to be effective in reducing injuries like you think it is. They rank strength training as number 2, specifically focusing on your core and your hamstrings. Balance training is number 3. Balance training and stability training is becoming a lot more popular in injury prevention programs for good reason, but the level of impact of this additional balance and stability focus is still unclear. Agility in a training program is going to be specific on the sport, making sure you're doing agility exercises that are specific to your sport in different directions, making sure you're doing the same kind of movements you would see in a game of the sport, and then stretching was ranked last. So using the FIFA 11 as an example, I'm not going to go into the specific exercises because this is online and you guys are all probably pretty familiar with it, but just going over the design of a program. So the FIFA 11 was originally designed for soccer athletes, although it has been shown in the literature to be effective for other sports. And it does start with agility. So it is having the athlete moving, getting to run in different directions and making sure they're aware of their environment and their surroundings. Part 2 of a 3-part program is focusing on strength, plyometrics, and balance. I pulled the strength exercises here to show that there is a focus on core and hamstring. It's also important to make sure you're incorporating levels of difficulty. If the task in the program is not challenging the athlete, it's not going to be as impactful. And so in the FIFA 11 with the single limb stance, the balance training, they do make it harder by having them pass the ball with a partner or challenging your partner politely and nicely, not shoving them to the ground, but making sure that the stance task is being increased in level of difficulty. And then lastly, with the plyometrics of this part 2, they do a good job of providing cues and correctives to the athlete. Like I said earlier, if you have them do plyometrics, so you're having them do these high impact movements that they're going to see in the game, if they're doing them incorrectly, you're not going to have an impactful and effective program. So making sure you're correcting their techniques in an appropriate way and making sure they're moving correctly. And then lastly, the FIFA ends with agility, increasing the impact of the running exercises. So going back to the umbrella review, there was no consensus on the duration or frequency of an intervention, although they did generally recommend to begin in preseason and continue into season, at least weekly, if not more, potentially declining the frequency as season begins. And compliance is key. We all know if we're in the medical field that if they're doing stretching or if they're doing a program, a neuromuscular training program, if they don't actually complete it and they're not doing it consistently, it's not going to be as impactful. So making sure they're compliant and making sure they're moving correctly. The FIFA 11, for example, has a duration of 10 to 12 weeks to be effective and to see a reduced rate of injuries and a frequency of at least 2 times per week. Thank you.
All right. I'm Phil. I think I know many of you, but if I don't, Phil Wilson, one of the orthopedic surgeons here. And this is an exciting topic for us because it's kind of the canary in the coal mine for pediatric sports, right? It's a high volume problem. We think we know a lot about it, but we haven't solved it. It causes a high burden of disease, and it spans operative and non-operative problems. So I think it's a great topic to discuss. You know, I think what you just heard is the key, right? Prevention, and that's what we want to do, but unfortunately that doesn't always work. And then, you know, when these kids get injured, I think that we definitely want to consider non-operative treatment. And as you can see our algorithm here, we want to start out that way, and I think it's very reasonable, but unfortunately at this point, we don't really succeed non-operatively. A lot of kids convert to operative treatment, so we're going to talk a little bit about that. Now, I would tell you guys, Dr. Ellis is an incredible national advocate for us, both at the state and the national level. He's an incredible leader. He's been active on some of these clinical practice guidelines in addition to this ACL guideline. And so a lot of what we're talking about is supported by our national sort of recommendations. But when we're faced with treating an ACL injury, we're worried about maturity and about the growth plate because, as you know, we typically anchor a new ACL. We can't repair the ACL most of the time. And so we anchor a new one in the bone, but we got those growth plates in the way in these kids. And so what do? And the main key is the more growth they have, the more we want to stay out of the growth plate. The less growth, then it's okay to anchor it in the bone. And we're really talking about that thigh, right? The femoral growth plate, because that's growing about twice as fast as the tibia. And so this kind of tends to be our treatment algorithm. On the left side there, if they've got a lot of growth remaining, then we try to go around the outside of the bone. We build a new ACL without anchoring it in the bone generally. In that middle section, when they've got some growth remaining, but they've kind of slowed down, they're kind of slowing in their growth, they've got some left but not leaps and bounds, then we do anchor it in the bone. I've kind of grayed out that one option. It's still an option that we talk about, this all epiphyseal fixation. But we think there are some reasons why it may not be best, and we'll touch on that, but I just want to include it for completeness. And then as the right side there, if those growth plates that you see represented are closing down, then any tunnel and screw position, any autograft that is reasonable in kids is an option at that point. So we're going to start with those youngest kids. What do we do when there's lots of growth left? Well, this procedure has been our mainstay for several decades now, and this is where we use part of the iliotibial band. The iliotibial band is uniquely positioned to help control the knee because it's anchored on that lateral side of the tibia. And as we know, that pivoting or that rotational movement is a key problem with ACL. So if we take that iliotibial band, we leave it attached to the tibia, we bring it around and then through the knee, then that iliotibial band is really helping us control that relationship of the femur and the tibia. And this is kind of what it looks like. We anchor it in the metaphysis. It comes through the knee, comes down across the epiphysis, and then anchored on the front of the knee. This is what it looks like when we do it arthroscopically. We're pulling that ligament through, and here's the new ligament. Kind of looks like an ACL. Pretty cool. Here it is on an MRI. So you can see on the sagittal view on the left, there's a new ligament that we built. You can kind of see it coming around the growth plate there at the top. And then on this axial view, you can see how it comes from that right side, lateral side, around and then through the knee. So you can see how it kind of yokes or connects the tibia dynamically to the femur. So when these kids cut and pivot, you've got kind of this new control point. Kid on the left there had surgery. There is scars, and here's how we watch their growth. And fortunately, we've seen that this is a pretty great option. 94% graft survival. That's a pretty good rate of graft survival. And really low complication risk, okay? So we see kids grow predictably, low risk of complications, fairly good graft survival. So we love this for our younger kids. As kids get older, we've kind of felt, wow, they need a bigger graft. We need to anchor it in the bone. They're almost adults. Let's figure out how to do an adult-style surgery. And so this is where we think about anchoring it in the bone, and how do we do that safely? So we call that transphyseal reconstruction. And so what we know, the principles that we use are, if kids injure a growth plate or growth plate gets injured, if we cut out the zone of injury and stuff it with soft tissue, sometimes fat, sometimes other soft tissue, the growth plate can grow. It's like creating a hole in a donut, and the rest of the donut grows around that donut hole. So we use that principle And we know the physis responds well to that. So if we anchor the graft, but we don't put implants or bone across it, we know that that can grow. And that tends to work out predictably if the growth rate is not too significant and if we put the graft in a reasonable position. So here's a view of what that looks like. On that top right, we're looking through the bone. That's where we've drilled the red bone in the deep part. That's the metaphysis above the growth plate. Then you see the white growth plate. Then you see that sort of less vascular epiphysis. And there's that new ACL. This is what it looks like on an x-ray. You can see on that left-hand side, there's a little white line next to that button. That's the growth. That's kind of like a tree ring. We call it a Park-Harris line. That's the growth that we can see that occurred since this kid had surgery, and we monitor their growth. So the outcomes are pretty good. It's a pretty highly studied surgery. The patient-reported outcomes are fairly good. The deformity risks are relatively low when we use correct principles for that. But unfortunately, the graft re-injury rate's kind of high, higher than we'd like, 10 to 20% overall. But when we look, that younger graft, 5% re-rupture. This older graft, maybe 15 to 20, even though the kids report doing well until they get re-injured. And if we really look at athletes who get that surgery, there's an even higher rate in athletes. So what's going on? Why are we doing a pretty good job in younger kids and struggling in these older kids? Well, we looked at some of these challenges. We said, maybe it's the graft position, the size of the graft, what type of graft people are using. So with graft position, getting that graft low, really putting the ACL where it's supposed to be, that's become really important. We think we're getting better at that. So looking at graft position has been a big key, and we think we're improving. We looked at graft size and found that when we used hamstring grafts, you had to be above a certain size. So size tended to matter, and that's another technical point that we've learned. You can't have too small a graft for these kids. And so whether it be using a larger hamstring graft or sometimes maybe even changing our graft choice is something we've looked at for kids. But then allograft is something that's used in adults. And we used allograft at times in kids for different locations, but inside the joint it seems to be a really bad choice. What we found is allograft fails very, very high rate. And so we've learned that we shouldn't use allograft. So we're learning a lot of things about these grafts. But one of our main challenges, Sophia touched on it, is this neuromuscular control and high activity levels. So what do we do about all that? How can we try to help beyond the physical therapy and the training and the neuromuscular control activity? How can we help that? And so this is kind of the physical therapists in the room see this patient every single day, right? This is knee valgus collapse, right? Poor abductor control, valgus collapse of the knee. And then when you have that, in a static sort of in the exam room, it turns into this on the court, right? And so that knee valgus collapse, how do we control that? What can we do as surgeons to try to help that? And so we know that rotational control is a huge challenge. How do we help with that rotation that the tibia is doing underneath the femur? And so what we've learned in orthopedics is we need to pay attention to our history. And in orthopedics, we've known for a long time that iliotibial band really helps rotation. It's sitting in a unique position. And so there's something called a lateral extraarticular tenodesis that we do across all ages using the iliotibial band to control that tibia. And if you remember, this is the same thing that we do in our younger kids, and we know it works really well. So what we started doing about a decade ago and have had a chance to report on is that if we use that iliotibial band in the same way we do young kids, but add it to a primary graft in these bigger kids that may need a bigger graft, then we've been able to control the knee and reduce those re-injury rates. And this is kind of what we saw in one of our studies, is we got that re-injury rate cut quite a bit. So we tend to think about adding lateral control for all of our kids, whether they be the youngest kids or whether we feel like they're a little bit bigger and need a bigger graft. And you've heard about some of these risk factors, right? Those neuromuscular risks of rotation. Ben told us about the tibial slope, and female sex we've heard is a big risk factor. And so we think about this a lot. And again, these kids push us, right? Everybody in the room and everybody online takes care of these kids, and they're tough because they're kind of our highest risk population, and they go out and test this thing. So we have a strong consideration for lateral control in all of our age groups, and we think that's helping us get a little bit better and lots of room for study. But as you've heard, we're still not there, right? And compliance, this is one of our biggest things. You know, kids push us, and we try to check all the boxes. How do we keep them safe? But this return to play, how do we retrain them? How do we get them to slow down? How do we get enough time for healing and neuromuscular control retraining? So I think Jessica is going to talk to us about that. Thanks.
All right, thank you, Dr. Wilson. I'm Jessica Dabis. I'm a physical therapist here, and I'm going to talk about return to play decision making today. So I want to start by talking about the landscape of return to play. We know that around 65% of our patients that undergo ACL reconstruction are going to return to their pre-injury level of sport. And of the patients that return to any level of sport, up to 29-30% or so of them are going to experience a re-injury either on the same side or contralateral side. We also know that the reality is in stark contrast with the expectations of 91% who expect to return to that pre-injury level. So among those that return, less than 34% of them undergo or pass a return to play test battery before they go back to sport, which is pretty low if you think about it, right? We're talking about how important test batteries are. Less than 34%. The good news is that for those that do pass a return to play test battery, there's a significant protective effect with a reduced rate of re-injury of up to half or 75%. So we know from this that it's important and valuable to have return to play test criteria and batteries for our patients, and it's protective for them. We just need a way to organize the multiple factors that we would consider and prioritize the information that we gather into some sort of framework for our decision-making process. So enter the START framework, and some of you may be familiar with this. It's from the 2016 Return to Sport Consensus, and it's a useful tool for organizing the variables we want to look at across 3 categories. So we're going to look at the health risk of the patient, the activity risk associated with the sport, and then finally assess the risk tolerance from the point of view of the stakeholders. So let's take a look here. So the step 1 is going to be that the medical risk factors, which Ben and Dr. Wilson did a great job of talking about. So I won't spend too much time here. A lot of these are non-modifiable. One of the modifiable factors here is going to be weakness, and we'll talk about that in a bit. So once we've looked at what are the factors that are going to apply some constraints for us, we want to look at step 2, and this is going to be our activity risk. It's going to be specific to the patient, the sport, a level of play, and the position, right? Is it a multidirectional sport? Is it a pivoting, collision, contact sport? Is it linear? Is it a more defensive reactionary position versus a more anticipatory position? And then, of course, the level of play. On our end, a couple of ways that we assess this is going to be functional tests from a therapy perspective, looking at that activity tolerance, and then psychological readiness is also useful in assessing how that affects activity risk. So finally, we take the information that we gathered from steps 1 and 2, and we're going to present them to the stakeholders, which is going to be the patient, their family, their coach, future college coach, and they're going to bring their priorities to the table to give it context, right? This could be the timing of the season. Is it about to be playoffs? Is it off-season, tryouts? This could be the level of play, pressure from the athlete or the coach based on their importance to the team, or this could be scholarship pressure, right? We're all familiar with these when we have these discussions in the clinic room. All right. So this gives us a good framework to operate from in terms of the decision-making process. Now we just need to prioritize and gather the information that we're going to insert into this framework. All right, so let's talk about what's the most common criteria used. So I like this visual from a 2019 systematic review by Berge et al., and it shows us the proportion that these factors were included in studies as well as the evolution of time, right? And we know time's always been the most common factor relied on. So I'm going to talk about time, strength, and hop testing. All right, so let's start with time, and I also snuck level of sport in here as well. So with respect to timing, this is going to be our step 1, biological healing. And what we know is that 9 months comes out in our population as a pretty consistent demarcation line before which there's a significant increase in re-injury risk. So along with that, there's a similar trend with level of sport. We know that level 1 pivoting sports and the 6 or greater Tegner score are also associated with a significant re-injury risk. So this goes into that step 1 of biological healing and that step 2 of activity risk that we're going to put into the framework. So let's talk about strength, right? This is one of those step one and functional factors. We know that after any knee injury or surgery, quads are so important, right? They affect multiple facets of function, and they are very important. However, it's important to know that a knee extension strength test can never be the only determinant of function, right? And Dr. Wilson, Ben, and Sophia have all talked about and alluded to the neuromuscular influences on this injury sequelae. So a few things here. Limb symmetry index does a notoriously poor job as an arbiter of function because there's significant deconditioning of that postoperative and contralateral limb, and we can't ignore there's also central nervous system bilateral systemic effects that affects both limbs after injury. We also see that both high quad index and low quad index patients show sagittal knee alterations in their landing mechanics within that first year after surgery. So that tells us or highlights that we've got to use both qualitative and quantitative measures. And then finally, we can't ignore there's neuroplastic changes associated with the loss of those ACL mechanoreceptors, and that's going to affect the knee stability strategies. So a couple of takeaways here real quick. Limb symmetry index isn't going to give us the whole picture. We might want to think about something more like a normative index, right? We know they're not going to hit the age-matched normative controls in the first year, but we might aim for a % or aspiration towards that rather than LSI, and then we've got to use qualitative information as well. All right, so let's talk about HOP testing, and this is going to fall into that step 2 functional testing category. In HOP testing, it's clinically feasible, so it's usually the most common that's been used historically. And when we think about a functional test, we want it to have content validity, right? We want it to measure what we think we're measuring. So if we say we're measuring knee function, we can look over at this graphic here on the right that compares the propulsion phase of the horizontal hop versus the vertical hop. And you can see in that middle teal section, that's the amount of work that's occurring at the knee joint for each of these. So if we want to measure knee function, it looks like vertical hop is probably the best bet for us. All right, so we've got the framework and we've got all this information. To tie it together, I took these, pulled some of these key themes from this 2020 consensus statement, and this highlights the elements that I think are most important in terms of the systematic process on how we want to make this decision. So this is the method of how, and the framework and criteria are the tools that we're going to use to do that, right? It's got to be multidisciplinary, we've got to include stakeholders, and we've got to include factors like psychological readiness, which Dr. Stapleton will talk about. Right. So, quick wrap up, key takeaways here are we've got to find a framework that assesses multiple variables, not only medical, but also non-medical as well. And we can use some of these criteria to establish our deal breakers, right? What do we know is unsafe? After that, I think we all know we've got to get used to living in the gray area, because that's where a lot of these conversations are going to occur. And finally, education, 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 right? We know there's such a disparity in the expectations. If we can frame those expectations along the way and educate the patient, it's going to make for a less confusing conversation when we get to that return to play testing day. So that is, these are my references, and I'll go ahead and hand it off to Dr. Stapleton.
So I'm Emily Stapleton. I'm the psychologist that supports the sports medicine department here. To start, I just want to overview the integrated model and the biopsychosocial model to psychological response to injury. So these models highlight the individual differences that all athletes experience when they have an injury. As we all know and have probably seen, athletes do not all respond to injuries in the same exact way. Some may respond with anger, frustration, anxiety. Others may not. They may experience a sense of relief with an injury. When examining from a biopsychosocial lens, we really want to, we assume a direct relationship between the cognitive, affective, and behavioral responses to injury and psychological and physical rehabilitation outcomes, such as quality of life, treatment satisfaction, return to sport status, and all of those factors are moderated by pre- and post-injury factors residing with the injury, or athlete, excuse me. In general, let's see if I can do multitask up here. In general, negative emotions increase immediately following an injury and are greater than they were prior to an injury, as one would likely expect. These emotional disturbances are, for the most part, not of significant magnitude or duration to meet clinical significance for a mental health diagnosis. That being said, 5 to 24% of injured athletes do have clinically significant mental health concerns that warrant intervention from a mental health provider, as following an injury with those with severe mood disturbances are at risk for a suicide. In general, though, mood does improve over the course of an injury. That being said, 2 studies have identified an increase in negative emotions and a decrease in positive emotions as athletes near the end of rehabilitation and return to sport, possibly indicating challenges with apprehension with return to sport and increased fear of re-injury. Several risk factors, pre-injury risk factors, exist for significant emotional disturbances post-injury. High athletic identity, those who are dispositionally anxious, those who have high investment in playing professional sports, those with higher levels of sport involvement, those with previous injury history, those with more severe injuries, are all at risk for greater emotional disturbances, and those with low social support and increased social withdrawal are also at risk for challenges post-injury. Looking at post-injury factors, so to rehabilitation, though, especially looking at negative mood states like anxiety and depression, we know that those with experiencing negative mood states tend to recover more slowly. Greater emotional distress following an injury has also been associated with the tendency to interpret pain in a more catastrophic manner and attribute an injury to something that was residing within themselves that they had control over. Regarding mental health concerns, anxiety and depression have been linked to increased post-surgical pain as well as chronic pain complaints. And then looking at adherence, anxiety and depression both have an impact on adherence to rehabilitation protocols and home exercise programs. If you think about depression, depression negatively impacts motivation, energy, interest, which could have a negative impact on adherence. And looking at anxiety, especially anxiety related to movement and pain, those with anxiety often engage in avoidance behaviors, which then decrease adherence. I think it's important to highlight the pediatric fear avoidance model very briefly, as this is a major contributing factor to emotional distress, avoidance of exercises, and return to sport. In this model, if pain is interpreted as threatening, pain-related fear develops, and with pain-related fear, it can lead to avoidance behaviors and hypervigilance. Looking at adherence. So adherence is one of the major behavioral responses to injury that we look at, and it's closely tied to athletes' emotional and cognitive responses to an injury. Adherence can act as a mediator between psychological factors and rehabilitation outcomes, but it's difficult to measure, and it varies widely, as many have kind of spoken to today. There have been several psychological factors that have been found to contribute to rates of adherence, including increased pain, emotional distress, low athletic identity, and low self-efficacy. High athletic identity has actually been found to put an athlete at risk for overtraining over adherence. When looking, as many have spoken about today, despite advances in surgical techniques and rehabilitation, there's a persistent subset of patients that are not achieving return to sport after ACL reconstruction. The relatively low rate of return, despite high success with surgical techniques and rehabilitation, suggests there may be other factors contributing to the return to sport factors. Such as psychological factors. And so some of those factors that have been identified in the literature are psychological readiness, as Jessica touched on, fear of re-injury, desire to return to sport, locus of control, self-efficacy, pain catastrophization, and athletic identity. So although the current literature shows that psychological factors identified pre and post-operatively can have a major impact on return to sport status, there's no set of guidelines for everyone to follow in terms of what to do when you identify these at-risk patients. unfortunately. For the purpose of this talk, I'm just going to highlight two of those factors. I know Jessica spoke to psychological readiness, so I'll kind of expand on that. First, psychological readiness is characterized by, although it is multifactorial, it's mostly characterized by high levels of confidence to return to sport and perform well and not get re-injured, as well as low levels of fear and anxiety. It's often measured by the ACL return to sport inventory, and this factor has been most strongly identified with or associated with returning to sport, the pre-injury level. Fear of re-injury is another important factor, as kind of highlighted by that pediatric fear avoidance model. So it can negatively impact physical impairments, the recovery of physical impairments, reduce self-report of function, and prevent a successful return to sport. It's measured by the Tampa scale of kinesiophobia, and fear of re-injury is the most commonly self-reported factor that patients say inhibit them from returning to sport, with 24 to 35% of athletes reporting fear of re-injury following ACL reconstruction. When looking specifically at rates of return to sport, when psychological factors are present, rates of return to sport are lower, and if they do return, it takes a lot longer. Some preoperative assessments of motivation can predict challenges with return to sport, and in a prospective study, low motivation, low athletic identity, and psychological distress were identified as pre-op predictors of post-op outcomes such as knee laxity. Looking at post-op predictors with challenges with return to sport, increased fear of re-injury, low psychological readiness, low confidence, and low locus of control have been identified as post-op factors that inhibit athletes returning to sport, or predict, sorry. Early identification is key for psychosocial factors within rehabilitation because these have been found to be modifiable early after ACL reconstruction. Specifically, increasing self-efficacy and fear of movement have been shown to predict improvements in knee pain and function. So focusing on interventions like goal setting, stress management techniques, cognitive restructuring techniques can all be really important because using these skills aimed at increasing self-efficacy and decreasing fear of re-injury can have a positive impact on rehabilitation outcomes. These are just resources we put together at Scottish Rite to help support with fear avoidance, pain management, and get our athletes back. Again, there's my resources.
Well, I'll start. Dr. Ellis, why don't you kick us off?
Well, I always have questions.
I know you do. This whole thing is just for you, this whole Tuesday thing.
My first question, and I'll save my second question for later, but my first question is talking about ACLs and, the real nuts and bolts of it is really injury prevention. And so my question, and I'm sure a lot of us have gotten this in our practice, is, at what age do we need to start worrying about this? We have many of, pediatrics, your 10-year-old is very different from your 16-year-old. And so does my 10-year-old need to start worrying about injury prevention? Or does my 16-year-old, or when is the right spot if I really am a parent or a therapist or, a trainer of a youth athlete? When do you recommend, and in what patient do you recommend the initiation of an injury prevention program?
Sophia, why don't you kick us off?
Oh, there we go. It's a great question. I'm not sure I'm the most qualified to answer, but I'll give a crack at it first. I think it depends on the sport. I know I've had some conversations with you, Dr. Ellis, and I recently heard Dr. Grady speak to this as well, that it depends on what the program's targeting and the sport they're playing. So if you have a soccer athlete in middle school, they're going to need to be focusing on coordination more than performance necessarily. And then when you get to high school, there's a different focus and a different level of injury risk there that may be based on age, sex, and sport. But I'll let someone with a clinical background answer that. Dr. Wilson?
No, I think that's a perfect answer. I think unfortunately I think it's an evolving topic. I think injuries are occurring at different ages than they have traditionally, and I think that we're kind of learning on the fly. And I think many of our kids are at risk that we wouldn't have otherwise thought in the past. And so I'd like to segue into another question for you quickly. Injury prevention seems to work. Why are we not doing this? Why is this not mandated in the ISDs? Are we in this room falling short as advocates? What's up? Yeah.
I think that's a great question. I think there's a lot of different answers. I think implementing an injury prevention program, depending on how you do it, is a little bit costly. It's also going to be based on sport, based on sex, based on age, and having the qualifications and the experience to know what you need to put into an injury prevention program based on the population you're taking care of is important. So I think there's a lot of answers to that. I think in implementing some kind of program with your athletes, whether you're a coach or a trainer or a PT, is extremely important. And then making sure you're doing the research to know what components your population needs. Like we just talked about, a middle schooler is going to need something different than a high schooler. Did that answer your question?
Yeah, no, I think it's difficult. But Ben, what was the number? What's the cost?
$8.5 billion.
A lot. It's a big number, right? So in the last decade, we have seen from the top to bottom multiple modifications in play rules, return to play legislation regarding concussion. As far as a utilitarian approach to lifelong cost from sports injury, preventing an ACL might save as much or more money. So you presented a lot of risk factors. We have return to play. Why are our legislators not asking us to change play to address risk factors to make sports safer for ACL injuries? We used to not think it was possible for concussions, right? I think somebody recently said put a dress on them or something regarding protecting the quarterback. But we've had a lot of rule changes. And so why can't we do that for the ACL?
I don't know. That's a great question. I feel like with concussion, it took a lot of time to get there, but there are some immediate rules you can put in place to reduce. We know what to do in order to reduce injuries. With ACL, I don't think that we know exactly what we can do quite yet, but
it sounds like we injury prevention protocols, playing surface, maybe some rule changes about specific patterns that are allowable and not allowable in certain sports. Anyway, interesting question,
totally agree.
J-Dab.
Oh, yeah, no, that's a great question. I also don't have the full answer, but it makes sense what Sophia says, that there's not, again, a protocol that's going to ensure that we put them back to play safely. There's those unmodifiable risk factors. But real quick plug, when we talk about concussion, not really plug, I'm not sponsored by anyone, but when we talk about concussion and the impact test, right, that's something that also with respect to ACL, studies have shown that lower scores on certain visual processing, reaction time, et cetera, have been linked with those who have future ACL injury. So speaking of the ways that we can try to target, again, injury prevention, that goes into the neurocognitive and the unanticipated nature of sport. There's some ways that we can think about, okay, can we give some sort of test to identify those who are at risk? But again, there's no way to control for all the factors.
Just
30
to
seconds.
add to that,
30 seconds.
She brought up screening. I think screening is a really interesting point that could go to policy. I know screening recently in the research has been shown to be cost not effective or efficient, but if we can make headways in that, just like with baseline testing for concussion, I think that would reduce.
So treat them all. Treat them all may be cheaper.
It would be cheaper, but I
Maybe
think
treat all the females, not treat the males, just forget those guys?
No, you should treat both the females and the males, but
Okay.
I think if advancements can be made in screening, that could help
Yeah,
reduce
but this is
the
Texas.
effort.
We're not going to mess with football.
No, definitely not.
Okay. All right. J-Dab, 30 seconds. Okay. We see a lot of information in the press recently that because of changes in lifestyle and culture, our society is not as fit as it used to be. We may not have an effective military. So as we look at that, and we realize that kids are maybe less and less fit. How can we use the other leg at all? Maybe the other leg is so pitiful. Why do we match up to the other leg?
Well, it's a great point that's one other reason that we wouldn't consider limb symmetry index. And in terms of the cultural and lifestyle factors, this is where when we get back to the first question of, different ages require different interventions, but we're always thinking, I know the therapy department, we're always talking about long-term athletic development, right? It doesn't necessarily have to look like sport, but ideally we're working towards long-term movement competency and development, some level of activity to, prevent the limb symmetry index from being completely obsolete. But we know for those that are intending to get back to sport and want to be compared with age-matched controls, we can't compare to a deconditioned limb.
So we're going to give you 9 months. You have to make them an athlete, tune up the other leg, and then get the injured operative leg to match that. So there's 9 months. So 9 months, we say that 9 months, there's data to suggest that shorter is bad. Have we really looked at longer, or are we just scared to do it because we know nobody would comply with even longer than 9 months?
I think that is very true, right? Because some studies show that, or say that 2 years is the amount of time you should wait. But we know who's going to wait. I mean, after 2 years, are you even going back to sport, right? So there's got to be that balance, the practical and the complete scientific perspective. But yes, that is the assignment. We have to get them ready for anything at a very high level by the time. So 9 to 12 months.
Dr. Stapleton. I'm always concerned about the parental-patient relationship, and I think there's a dyad there that is highly influential on the patient and their mood and recovery. What can you tell us about that? How should we be assessing the parent's role, and how can we treat the parent?
Well, that's a very complicated question to answer.
That's okay, 30 seconds.
I don't think you can treat the parent, assess the parent necessarily, but what you can do is provide ample psychoeducation, preventative strategies for setting boundaries, stress management, how to help them cope with adjustment to concerns throughout the injury in order to maybe get in front of any potential challenges that may arise throughout the course of rehabilitation. I think being very explicit from the very first visit about expectations with the parent is key, because a lot of times the parents may be putting extra pressure on the child to return too soon. And that extra stress, we actually know, talking about injury prevention, anxiety, and stress, whether that's kind of chronic daily stressors like homework or just family stress, or major stressors like loss of a family member or friend, it put athletes at increased risk for injury. And so we want to do everything we can to help support prevention of injury, but then also it's going to help recovery over the course if we can reduce as many stressors as possible.
Yeah, I think probably just anything we can do to begin to educate the families that they have such an important role, and maybe trying to identify different family types. Where do they come into the situation? And that goes back to patient type. And another question for you, as you said, the response to injury is hugely variable, right? An enormous bell curve. And some of these kids come in and, it's like you could put a hatchet in their forehead and they wouldn't even know it, right? It's not phasing them a bit, this ACL thing. And then there's others, right, that they are 100% somewhere in the stages of grief, right? That classic, 5 or 7 stage Kubler-Ross, right? Where do they come in? And so I wonder, should we, identify and stratify our kids, not only, how they're responding in general, but those that come in on that end of the bell curve? They're clearly in a grief process, right? As you've told us in the past, maybe they're not ready for surgery because of that, but how do we categorize those kids? How do we treat them differently? How do we help them through those phases? Where should we go on that?
I think having a grief reaction to an injury, a loss of a season, is totally normal and expected. It's, I think, more important to monitor where that grief reaction goes throughout the course of treatment. And so if you can get, I think, again, it goes to more preventative mental health intervention, and just this would be more cultural across the board. But if we can identify these patients and, give them screeners like we do every 3-4 weeks, we can get a better idea of kind of what's going on with their emotional state and provide those interventions. But I think having an appropriate, I would actually be more concerned with some of our patients who are totally not phased with an ACL injury and the loss of their season. Because that to me means they're probably holding something in, not processing it, and it's eventually going to come out later when it might be more problematic for rehab.
Or even worse, they may be unfazed and give us about 3 weeks of rehab and be back to play with zero fear avoidance.
Exactly.
Dr. Ellis.
Yeah, no, we have an online question that I think is a great one, so I want to be sure to ask it before we run out of time. The question is in regards to ACL injury following a concussion, as there is some evidence that may suggest that in the post-concussive phase, there may be some association with an ACL. So number one is, are we seeing this in kids? And do we have a protocol for concussed athletes to verify neuromuscular recovery or the forms of recovery to try to avoid an ACL? And again, I would defer to the panel or anyone else that has any expertise in concussion.
There was a study done out of Las Vegas that showed in kids that had had a previous concussion versus kids that had not, and adolescents specifically, the kids that had a previous concussion showed more biomechanical risk factors at the knee and hip, and they were therefore at higher risk of injury. Not a lot of research has been done into this, but we hope to in the future. Speaking specifically to concussion, probably Dr. Miller should speak to that.
Thanks. As Sophia said, there are studies coming out that are showing increased risk of lower extremity injury following concussion, and begs the question, you've heard neuromuscular control mentioned quite a bit, or are these kids going back to doing the same high-risk activities that caused their injury in the first place? We are currently doing a study here led by Sophia and her team in our movement science lab, assessing some of these factors when patients have perhaps clinically recovered, at least to the best of our ability to determine in the standard of care in terms of concussion clearance. We're looking at some of their movement patterns to see maybe are there risk factors there that are identifiable. So I think that is probably a future direction that you'll see concussion clearance have another component to it above and beyond the standard current care.
I'll just quickly mention that we shifted into concussion very quickly, and ACL injury prevention needs a better PR team. Okay, sorry. Any other questions? I know we're out of time. We really appreciate everyone's attention. Obviously, it's a very dynamic and interesting topic. We've got more questions than we have answers. We think that we're doing a reasonable job, but lots of work to go. So thanks to all of you who are part of the treatment team for these kids, and thanks for your attendance. See you next time.